My name is Kavita Patel from Washington, D.C. I want to take a little bit of a kind of a different tack. Those of you who know me kind of know that my background is mostly in the policy sphere around effective payment models. And what I'd like to do is kind of answer the question by asking the question, or at least throwing out the question, what does an effective primary care payment look like? Well, what is ineffective about what we're doing now? So let's just kind of highlight and recap. And the best way I know how to highlight and recap things is to go through my own clinical practice. I've migrated away from policy as my primary activity and moved into a primary care leadership role in my local practice, which many people in DC think I'm insane for, and personally I think has been one of the most fulfilling career moves I've made. However, what it's done is every single day reminded me about what's ineffective, not just about primary care payment, but this world we call primary care. On Friday afternoon, just 2 Fridays ago at 4 p.m., I got an automated discharge notice in our electronic health record system. All of you are probably familiar with this, about one of my patients who I knew had been admitted to the hospital. The hospitalists were calling me, many specialists involved, 62-year-old African-American male who had just recently actually found out that he qualified for Medicaid, so it had years of unkept medical attention that he needed to have done. I did as much as I could in the outpatient setting. He was admitted for shortness of breath, found to have bilateral pulmonary emboli, and through a comprehensive yet not so comprehensive workup, had a discharge summary that read as the following. This is 4 p.m. on a Friday. Bilateral pulmonary emboli, etiology unclear, likely cancer given recent weight loss and other labs, primary care to workup. Number 2, patient had recent loss of his wife had died about 3 months earlier from lung cancer. Number 2, severe anxiety during hospitalization. Patient was given multiple Ativan IV infusions with psychiatric consult, felt to be a grief reaction disorder, primary care to follow up. Number 3, unclear etiology of blood and urine, hematuria, urology consulted, initial bladder scan did not reveal any obstructions, primary care to follow up with urology visit in 1 to 2 weeks. How many people can get any sort of specialty visit in 1 to 2 weeks? I'd like for them to teach me because I need to understand that. Number 4, so this is interesting. We're starting to try to, I know we have a great speaker talking about social determinants of health. I applaud the fact that we're actually using these words. Our hospitalists had number 4 listed as housing conditions because he's not homeless, but he never had really stable housing. And in fact, he doesn't have a phone. It's really difficult to get in touch with him, and without stable housing and a way to communicate. The hospitalist actually noted on the discharge summary, number 4, housing condition. It's unclear if this patient's housing condition has contributed to his lack of primary care follow-up, primary care to follow up. So I immediately contacted, 4 o'clock on a Friday, I had to see some other patients, but I was worried that I was racing against the hospital clock. I immediately contacted the case manager who is affiliated with his inpatient case because we don't have great outpatient case management resources readily available, but I know we've got robust inpatient case management services. Case manager called me right away. I know it was the end of her day, and she said, yeah, this is a tough case, Dr. Patel. You'll just have to see him more frequently. And I explained to her that he has a job as a line order cook, and that he gets off of his shift at 4 o'clock, and I've been staying late to try to see him, but it's hard for him to get to his 3 buses to come to see me. And I said, do you think that there's any transportation vouchers, or is there something I can do to get him here quickly? And she's like, yeah, I can't think of anything. We don't really have those resources. So then I stayed Friday till 7 o'clock, and I waited for him, and he showed up at like 6:40, and I had nobody in my clinic to actually do anything. But I sat and I talked to him, and I just reassured him that we were going to try to figure out what was causing these clots. And all he could say to me is that He was just really sad because his wife died. So we just talked about his wife dying and what that was like. And when I had to sit down and write my note and how to code that, I couldn't come up with anything better than a 99213 because I didn't get into the 20 things that he needed. We just talked about one thing, and I didn't want to be accused of Medicare fraud, so I just built it as kind of simple and cleanly as possible as like a hospital follow-up. So in a nutshell, that's what's wrong with primary care payment. So what does effective payment look like? We have talked, there are studies, they're in your packets. We have talked about models. You're going to hear from a friend of mine, Rashika, about a model that's starting to spread around the country called direct primary care. There are effective models that are out there where we actually ask employers or patients themselves or people to kind of honor the fact that better primary care requires a different payment system. But then we have the elephant in the room, which is Medicare. Largely still fee-for-service, particularly in the primary care setting, largely still fee-for-service. And I call ACOs and patient-centered medical homes fee-for-service. If you might argue with me, but I still call that fee-for-service. So we still have a majority of our payments in our predominant public payers, Medicare, and some commercial settings as fee-for-service. And so we're still, just as Kurt said, we're still asked to do things on widgets and in 10-minute, 15-minute, maybe 20-minute aliquots if you're lucky. However, we need to rethink the model. So let's throw out a radical idea. What if we were paid like specialists? What if when I roll into my doctor's parking lot, the Toyota that I'm still driving when I was a resident, because I just can't afford something more than that and I had to pay off my med school loans, what if instead of the Toyota that I'm driving, I start to get paid the way our interventional radiologist does, who pulls up in his Tesla right next to me in the parking lot? What would happen? What would happen if interventional radiologists were paid what primary care was? And what would happen if primary care doctors were paid what an interventional radiologist or cardiologist was? And what would happen if we actually said that for this 5 to 6% of payments which currently go to primary care and the 95% of payments which are locked away in hospitals and services and labs and imaging, what if we actually said, all right, we're going to pay primary care accordingly, and it's going to be like the NBA or the NFL. If you want to do a certain coach, if you want a Golden State Warriors approach to your coaching style and you want to recruit players and you want to think about allocating salaries and resources to have that kind of an approach, that's fine. If you want to have a fixed budget because you're like the San Antonio Spurs and you have kind of an aging but steady work to what you do, that's fine too. And if you just want to piss it away like the Chicago Bulls, that's fine too. But you get what you get, and you have to own up to it. And at the end of the day, you have kind of your losses and your winners. And what if we actually come as a group, as primary care, together and say, we're going to own it. We're not going to try to work against each other. We're not going to try to have this comprehensive primary care model be the only one that's out there. We're going to try to figure out how we can actually be kind of a unified voice on this. What if that were to happen? What if instead of Michael Bloomberg and people who are big donors, all of you are at institutions that have names on them. I'm at Hopkins. We've got Bloomberg. We've got Kimmel, Sidney Kimmel. What if we actually had the Bloomberg Primary Care Building instead of the new Bloomberg Hospital or the new Bloomberg Immunotherapy Center? What if Sean Parker, instead of putting billions into immune therapy, said, I'm going to put billions into primary care? What would that look like? So it's not just about what we do and the Friday nights that I kind of stay awake worrying about the things I didn't do, which is actually true. I bet all of you have been there where you actually have like a moment where you've forgotten about something that you were supposed to do for a patient, and no matter how great your EMR is, no matter how great your team is, you carry that with you. How do we do a better job expressing, not that we have to have it all be about the money, but how do we do a better job expressing that this is actually why we went into the profession? And it really isn't about the 99213s and about the CCM payment and about the TCM payment and the advanced care planning payment and the modifier code that I need to teach my clinic and how to bill so I can get my extra $42 per member per month. That's not why we went into it. But we do need to have a better voice in describing what we are not getting paid for and how to translate that into a type of model that we can actually come together and agree on. And when I've worked in payment policy spaces, and right now we're talking about this big MACRA legislation, which is essentially, for those of you who have not paid any attention to it, it's kind of the end of the SGR and Medicare, but the beginning of a lot of questions around what does an alternative payment model look like? And can I just be in a level 3 patient-centered medical home and that's good enough? I'm here today to tell you it may be good enough for the government. It can't be good enough for us as a profession. If all we do is try to be somebody's accredited ACO or PCMH, we're not translating things into effective care, which is the most important thing, and the payment. And then I'll add to this, it's not just about the financing or the care that's delivered, it's about how these benefits are kind of explained to me, the beneficiary. When I get that card, when I get insurance, whatever kind it is, and I get that card that says ER copay $500, PCP $10, specialty care $20, I need people to understand what does it mean to have that relationship with me as a primary care doctor. I no longer want to just be seen as that person that's listed as follow up with primary care, follow up with primary care. I want that patient to feel like what I feel, that this is part of a relationship, and that relationship, turning that into something financial is complex and difficult, and that's the work we have to do. So today, when you're talking and discussing, I know we have discussion guides and questions. My number one question back to you is, what is it that you're doing in primary care that you wish would be more honored? Number two, if you're a policymaker and you have to think about doing something that applies to an entire country, how do you translate that into a policy? And then number three, how do we own up and be accountable for it, which means there will be losers. There will be LA Lakers one year, there will be Chicago Bulls another year, and every now and then you get a Golden State Warrior team. And so we want to be part of owning how we can be the best of the best, and then how we can teach each other to be the best of the best. No more divisions upon us, no more pointing fingers at us versus them when it's all of us. Because as I mentioned, my patient doesn't know that I'm in this battle for primary care payment. He just wants to go home and grieve for his dead wife. So thank you. With that, I'll let you get to the next part of your day.